Happy New Year, everyone. My name is Ashley Johnson, and my pronouns are she, her. Welcome to NAHUD's Bridging HIV and SUD Innovation in the Field webinar series. Today's session is Stimulant Use, Chemsex, and Evidence-Based Treatment, State of the Mind Field, and Future Directions. We invite you to use the chat to engage with your fellow attendees. Drop your name, title, profession, pronouns, and your city and state in the chat. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. Today's session will be recorded, and a PDF of the presentation slides will be added to NAHUD's website as a resource. You will receive this information in a post-webinar email that will be sent through Zoom. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS Education and Training Centers, ATCs, that support the ATC program mission. Established in 2010, NAHUD supports the ATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see feature resources, check out upcoming ORN events and trainings, learn about ORN work groups addressing health disparities, and more. There will be a post-evaluation survey that will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or a certificate of attendance. After 2 weeks, once the survey is closed, it will not be reopened. The minimum attendance requirement to receive CE is 60% of today's webinar. Participants who accrue less than 60% will not be eligible for CE. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. Each participant is responsible for verifying the requirements of their state licensing boards. Today, we have the pleasure in having Yona Tangi, pronouns they, them. They are the leader of medical substance use disorder programs at Whitman Walker Health in Washington, D.C., where they also practice as a clinician. They are the Associate Medical Director of Transgender Health at Amita Care, a nonprofit community health plan based in New York City. Yona is clinical ambassador for the CDC's Let's Stop HIV Together campaign. They are a passionate harm reductionist, researcher, and educator. Yona is president at GLMA, Health Professionals Advancing LGBTQ plus Equality, a clinical instructor at Yale School of Medicine, and the founder of chemsexharmreduction.org, an informational resource for patients and medical providers. Yona, take it away.
Thank you for that lovely introduction, and welcome everyone. I'm very excited to be with you all today. Let's go ahead and share my screen. Alrighty, and yep, as we go through, we'll have a good portion of time at the end for Q&A. So feel free to drop any questions that you may have in that Q&A box. Ideally in the Q&A box and not the chat, but we'll try and do our best to take a look at both. And yeah, feel free to keep on doing introductions in the chat and try and like get to know each other and network. So today we're going to be, let me go ahead and click. No, wrong button. Today, we're going to be talking about stimulant use, chemsex, and evidence-based treatment with a specific sort of like focus on the ASAM, or American Society of Addiction Medicine guidelines that came out in 2023. And now they have a really nice booklet form of them as well, that were a huge update to sort of like their guidelines on stimulant use disorder. And we'll talk about why it was so important and how it was like a very big change. And after we go through the guidelines and sort of break them down, we'll also sort of talk about the pluses and minuses, other like new research in the field, and what are the future directions and how this applies to HIV prevention and treatment. So I don't have any financial disclosures. I have perhaps too many roles and jobs, but I think that they were already run through. My primary roles is I serve as an associate medical director at a Medicaid plan in New York City. And then I'm also the head of our SUD program at Walker Health, which is a federally qualified health center in Washington, D.C., with multiple locations that focuses on the care of LGBTQ people, but serves a large portion of people living with HIV from all different backgrounds and walks of life. Alrighty. So like I said, we're going to be focusing on those ASAM guidelines, but in general, we're going to start off with some context, some level setting. I know that we have a pretty diverse list of people in terms of our registrants. I saw that there was a good number of caseworkers and social workers, so I'm going to try and also include some information there that is relevant. But again, if you feel like you need some more specific information for your clinical care context, please ask questions as we go through. So we'll start off with sort of like some level setting and baseline context. Then we'll delve into those guidelines, like I said, and also some new research for amphetamine use disorders and chemsex use disorders. And then we're going to talk about the limitations and future directions. So you have already started announcing yourselves in the chat. Please feel free to continue to do so. I'll move right along. Also, just for level setting, I wanted to include these definitions. This PDF of these slide decks will be available. And so I also just wanted to have that in there so that way for future reference, people wouldn't get lost. There are a lot of abbreviations in the research. Obviously, I'm not going to go through one by one and define all of these. A lot of you are probably already familiar with some of them. I'm only going to highlight a couple that are going to come up a couple of times. I like to use the term sexual and gender diverse. This is just a synonym for LGBTQ. They mean the same thing. It's just a different way of saying it. It also means the same thing as SGM, which is another research term, which stands for sexual and gender minorities. All you need to know is that this is like an umbrella term for, again, the whole rainbow of LGBTQ. I will also use the terms MSM and GBMSM. I don't love how binary they are in terms of gender, but they are the most common ones when we're talking about research, especially HIV prevention and treatment research. And then you'll see also that STUD, and that just stands for stimulant use disorder. And when we say stimulant use disorder versus meth or cocaine use disorder, we're kind of including all the stimulants in that umbrella. So not just any kind of amphetamine type, whether it be methamphetamine or prescription amphetamine, cocaine, etc. And the other ones related to HIV treatment, I'm sure looking at sort of the population we have here, you all are well familiar. So in terms of level setting, I always include sort of a definition of what I'm talking about when I say addiction or substance use disorder in a presentation. And I also always mention syndemic theory in every presentation I give. And the reason why, and one thing that I think is interesting about the field of substance use disorders and addiction medicine is that There have been multiple theories of what an addiction is, and that's evolved over time. But all of those theories are very much present today. It doesn't follow that same sort of like linear trajectory of our understanding of other things in science and medicine, where as a new theory that is more factual or more studied sort of like emerges, the old ones die out. Because there's so much stigma wrapped up in substance use, and also just sort of so many colloquialisms and sort of like conceptions of it. I think that all those things are really present. You still certainly see modern people who think of substance use disorders as like an issue of personal choice or morals. You'll hear a lot of people saying that addiction is a brain disease and that it's like a chemical imbalance, just like, and that it can be corrected with medications, or that we can see this chemical imbalance and that it's a chronic disease that once someone has it, they have it for life. And there's grains of truth in some of those theories, especially the genetic model, but it really is not the most accurate or holistic way to describe it. Many of you may have already heard, because it was developed in response to HIV, of syndemic theory. But basically, all I want to say here is that when we're saying what is an addiction, really an addiction is predictable and made up of all sorts of factors. And you really have to take in someone's intersectional identity when we're sort of understanding who is going to develop a disordered relationship with a substance. So sure, genetics plays a role, but what syndemic theory really is to me is applied social determinants of health. And that's like if you know someone's health status, whether or not they experience chronic pain, their education level, their economic sort of status, their like what community and zip code they live in, and if they experience any forms of oppression based off of either a racial or sexual identity or gender identity, you can actually predict in statistical models who's going to be develop that disordered relationship with a substance versus others. And that's because we know all of these sort of negative experiences, these important social determinants of health, can oftentimes interplay and combine. And that's what really leads to this disordered relationship with a substance. And that's really what I want you to think about when we're talking about addiction. I think when people talk about addiction too often, they just think of someone use a substance, especially in the context of this country, that is on a list, that is a list of bad substances, and therefore they have an addiction. But that's actually not true. The vast majority of people who use even hard substances, who use stimulants, cocaine or amphetamines, etc., don't actually meet criteria for having that disordered relationship. And so when we're actually talking about what a medical quote unquote addiction or substance use disorder is, this is what we're talking about, these DSM criteria. And there's 11 criteria for a substance use disorder, but I really like to break it down into 4 factors. And that's what it makes it much simpler when you're working with a client, whether again, that be through case management, through direct clinical care, et cetera, whatever your context is that when you're working with a client, and they're talking to you about their substance use, or you're asking them about their substance use, are you seeing that they are losing control of it? Are they using language like that? Like that they like perhaps it started out one way and it's transformed and they can't control it anymore. Are they having cravings for the substance when they're not using it? Are they experiencing social dysfunction? Are they failing to meet familial obligations? Are they losing social relationships or romantic relationships? Are they forgetting to do things like picking up their kids, etc.? And then signs of physical dependence and withdrawal. Are they using to feel normal? That's a lot of the times like one of the easiest questions to sort of get to that piece, is that have they reached a point where they're no longer using for perhaps some of the positive benefits, they're just using to feel normal. So when I say addiction and when we talk about substance use disorder today, this is what I mean. I don't just mean the use of a substance. And the point of me always starting presentations this way is to start to say, and I'll hammer this home quite a few times, is that as much as we would like to, there's no way to prescribe a pill to solve a substance use disorder. And the reason why is that, like I said with syndemic theory, a substance use disorder is not just based off of a person and a substance and some brain chemistry. There are all of these bigger factors that play in, experiences of depression that relate to our large structural societies, things like mental health, depression, things like pain, and then community-based problems like poverty, isolation, housing instability, etc. And there is no pill that we can prescribe as a clinician, or no thing that you can do at a therapist that fully is going to solve these things. And this is why interdisciplinary team models are so important. So I'm really happy that we have so many nurses, social workers, et cetera, here today, because everyone really plays a part in treating substance use disorder. It takes a community to treat it. And because when we're talking about moving people up and down this ladder, because a relationship with a substance can be worse or like kind of okay or bad. It's scaled even in the medical diagnosis. What moves people up and down the ladder are all of these things, not just those physical symptoms that as clinicians that we focus on and try to treat. And so when you know that, you realize that when we're thinking about effect sizes and thinking about what we can accomplish, a medication, like I said, is just not going to do all of this. And we need to work as teams. We need to do case management, et cetera. And all the same stuff that we are going to apply to substance use disorders also applies to HIV, and they're quite intimately interconnected, especially when we're talking about stimulant use, and especially when we're talking about stimulant use in queer communities. So I just wanted to go over all of that as a bit of a baseline in terms of theory. And then now I'll move into some epidemiology as well. So we're going to be talking about stimulant use disorders in both heterosexual people and queer people, but we will be focusing in on chemsex or sexualized drug use, which is the use of drugs during the sexual experience to enhance or enable it. So I wanted to start off also with some baseline epidemiology, just kind of showing the health disparities between sexual and gender diverse people and people who are not. So in these different graphs and in this paper, or these papers that we have here, what they tried to do is sort of look at the rates of substance use disorders between LGBTQ people and cis heterosexual people, as well as between trans people and cisgender people. And basically, in the data that we have, we can see that in general, LGBTQ people across the board have higher rates of substance use as compared to their cis heterosexual peers. And when you further extrapolate that up between cisgender people and transgender people, regardless whether the cisgender people are heterosexual or have a different sexual orientation, that the people who identify as transgender have the highest rate of disordered substance use. And that is not about innate quality or genetics. It's really about what I was going back to with the syndemic theory about how the experiences of oppression make it more likely for someone to develop a bad relationship with a substance. And you know, the reason why I always like to say relationship is this is the same thing we see in other kinds of relationships. And it's not just relationships with drugs. People who go through more hardship have more of these sort of like ACEs or negative social determinants of health or sort of negative structures affecting them. They develop negative relationships with other things too, and with resources, etc. So all that is to say is one of the reasons why we're going to talk a little bit more about stimulant use in the queer context is that it does affect this population at a greater rate, and it definitely is also intricately related to HIV. So why is it important to talk about stimulant use? Well, you know, we talk a lot about opioid use as it relates to HIV and viral hepatitis prevention. But again, especially when we're talking about the queer community, it's really important to focus on stimulant use. And actually, there's research out there that's showing that when we're talking about injection drug use in sexual and gender diverse people, the vast majority of it is actually not opioid use, but stimulant use. Now, some of these are international studies, but at some of the lower levels in terms of prevalence data, we get also from departments of health and from different health clinics, et cetera. We know that this is likely also true in the United States as well, as that, again, the vast majority of injection drug use in queer people is going to be stimulants, specifically, especially methamphetamine, and not opioids. And we know that the sexualized use of stimulants, whether it's injected or inhaled, is, like I said, very associated with HIV and sexual health outcomes. So this is why it's so important to the work that we are doing in HIV prevention and treatment. And the other thing I wanted to show with these studies that are on this slide is that there's a bit of a different flavor when we're talking about the trans context. So when we're talking about transgender women versus gay, bisexual men who have sex with men, there tends to be a little bit more of crack cocaine use and a greater association with sex work. And again, we know that those people are just at a higher odds of developing a disordered relationship with a substance. So we see more of them proportionately participating in chemsex practices. Just again based off of the different experiences that they have and sort of those the predispositions from social factors to a disordered relationship with substance. So again, just some sort of grounding as we go forward. I get this question a lot, which is why I've included this slide. And I think that this study actually out of the UK is very interesting. There's some other studies too that are similar that have basically tried to look at once the idea of chemsex as a discrete sort of behavior has become more well established, is this something that we're also seeing in cisgender heterosexual people? And this study asked exactly that question, again in the UK, but somewhat similar of a context. And what they found is by and large, no. If you include cocaine and cannabis and alcohol in that, yes, you could definitely say that cis heterosexual people are participating in chemsex. But usually when we say chemsex, we're really thinking more about stimulant use and things like GHB or ketamine, et cetera, some of those other drugs other than alcohol, those illicit drugs. And so when we're looking at those, really there is quite a disparity. But again, where this applies to our research and why it's so important to understand stimulant use disorder is when we're working in HIV, is that for the cis heterosexual people that did have use of chemsex, in this study, they actually found it was more prevalent in people living with HIV who are cis heterosexual. So there's some intersection with those communities. And again, we know that all of these things run together, health disparities, along with a higher predisposition to various comorbidities, including things like HIV and viral hepatitis, et cetera. So hopefully that context is helpful. Now, the last study I wanted to highlight, sort of for background before we delve into the guidelines themselves, is a study that was published in 2022. And I really like the sort of the catchline of the study, and then I'll talk to you about how they got the data. But what they found and what's so interesting about this study, which is what they called it about the problem that we're not talking about, is that among sexual and gender diverse people, 1 in 3 HIV diagnoses were in people who were persistent users of methamphetamines. So that's a huge proportion or a big disproportionate population of this group of people where the HIV acquisition was likely related or to their stimulant use and the practice of chemsex. So it is important that we address this, especially in HIV context, because you can't do successful HIV prevention and treatment without addressing substance use disorders generally, but especially sexualized drug use and stimulant use. So this study, they had a pretty large group of people. They had an N of over almost like 4,003 and specifically again just looking at sexual and gender diverse people. They had a decent age range, but of course it definitely skews younger, 16 to 49. So we're looking at that like a population where we're most concerned about for new HIV diagnoses. Although, of course, we do also see diagnoses in older adults. And it was longitudinal. It was at 2 points in time over a 12-month period. And they did include actually an at-home HIV test. So it wasn't just self-report. And like I said, a good proportion of those people generally, of these sexual and gender minorities, reported any methamphetamine use, over 10%, you'll see there. But the most important thing, like I said, what was most of note was just that 1/3 of all seroconversions were people who were using meth persistently. And what they defined that as in this study is, again, they looked at 2 points in time. If you reported meth use at the beginning of the study and meth use 12 months later, that was in between there as well, then they were saying that that is persistent meth use versus if you just reported it at either point in time. So quite associated with outcomes. And this is specifically in the US, so US data, so that we know it's applicable to the work that we're doing. Okay. And so when we talk about the relationship between chemsex and HIV and viral hepatitis, the other aspect I want to highlight before we move into the guidelines is just that there's sort of a dual factor of this as well innately, because there's relationships with sexual health from the sexual practices associated with chemsex. And then there's the relationship with HIV prevention and viral hepatitis that come from the substance use aspects. So when we're talking about the substance use aspects, and we'll talk more about needs assessment later, we're talking about the route of administration, if they're sharing equipment, et cetera, and how that interplays with disease prevention and treatment. And we're talking about the sexual aspects. There are specific practices or uses of tools or lack of use of tools that predispose people or reduce their risk in terms of these other sort of outcomes, again, of HIV prevention and treatment and viral hepatitis prevention and treatment. And so that's what we're really sort of saying with this slide here. Now, I just want to give a brief overview of the guidelines, and then we're going to focus in on some pieces that I think are very relevant. So this is just an overview, basically, a very broad one of some of the things that the guidelines talked about. So one of the first points that they did is they really they reaffirmed the utility and sort of the importance of those known behavioral interventions that we already have, and saying that they really are first-line treatment. One of those being contingency management, whether on its own or combined with other forms of therapy. Now, I'd love to see in the chat too if you guys are familiar with contingency management, if that's something that you guys have programs for where you're working, and whether or not if you do have a contingency management, is that operating out of a drug use treatment center, or is that operating out of like an HIV program of some kind? I think that would be interesting sort of to know. But basically what a contingency management program is giving people prizes if they meet goals, and those goals being not using a certain substance. And again, it's kind of, to me, I always feel a little bit dark when I think about it, because it really just shows the importance and also the desperate need for social services, especially in the US context, because people will reduce their use of substances for basic need items like additional access to food and resources. And so the more that we can try and, again, do wraparound social support for these people, we know that that helps people reduce their use of substances and develop a more positive or controlled relationship. Now, the really amazing thing, which we're going to talk about, which was like a huge game changer, and is something, honestly, that I used to harp at ASAM about, and that I'm really happy that they have finally updated, is embracement of pharmacotherapies or different prescription medications to help people using psychostimulant, using stimulants or having a disordered relationship with stimulants. So for the longest time, ASAM kind of brushed off the concept that there were evidence-based therapies, saying that there weren't really any drugs that were useful. They especially really did not consider the use of stimulants, prescription stimulants, to treat stimulant use disorder. But that has changed with these new guidelines. And I think that is a really amazing change, because this is something that it can be hard to get a provider to do. And especially for those of you that are working alongside providers that are maybe not providers yourselves, having a guideline from a major society like this is so helpful in trying to get clinical providers who may be more hesitant to do something like this because they feel like perhaps it's because they don't want to, because they have biases, or because they perhaps just feel uncomfortable doing it. Having this guideline is really important because it will help people do that, and it will increase access by getting more people to feel comfortable with it. So that's really amazing. Now, they also really focus on co-occurring psychiatric conditions. And we'll talk about that specifically in relation to how they sort of like describe the different evidence-based therapies. And they really focus on treating those comorbidities. And I think that's a really positive thing, is that in general, HIV treatment, mental health treatment, substance use disorder treatment it has to be holistic. We have to address all the different pieces of a person. We also have specific content for young adults and other special populations that we'll talk more about. They have some specific information that's really helpful about acute over-intoxication of stimulants, so helpful for people who are working in emergency medicine contexts and hospitals. And so I think that's great as well, because there are not enough guidelines and care recommendations. And the other big thing that was truly really great, I think, about these new guidelines is an embracement of harm reduction for stimulant use disorders and specific information categories. And we'll also highlight those within the guidelines. And so, yeah, I'm happy to hear or see some people in the chat also talking about contingency management programs. I love that I see that someone has one at an HIV program. But yes, I also see one of the biggest problems really is about funding. It's very hard to find funding for contingency management programs. And unfortunately, a lot of the biases around substance use and the stigma around substance use disorders and addiction prevent funding for these kinds of programs, especially in our context where we live in a society that is very concerned about the concepts of like handouts and social support systems, even though that we know in the general, they actually save people money in the long term and have quite positive effects in terms of health and public health. So to start off, sort of at the beginning of the guideline, one of the things that it does is it offers some exact information on how to do an initial assessment for someone presenting with a stimulant use disorder. So this is really helpful. It kind of goes through the things to screen for, goes through physical exam, etc. It's a really great thing, I guess, especially for also younger clinicians that perhaps feel a little bit more hesitant. It can be a really great way, again, I think this whole guideline to get more clinicians into doing this kind of care. So it just goes through all the different concerns, things you want to ask, etc. One of the things that I also want to highlight that I think it's really great as it does is it goes through also the DSM diagnosis of a stimulant use disorder. So again, it's very common for people to equivalate use of a substance with an addiction or a use disorder, and that is not correct. The correct and most proper thing to do is to go through those criteria as a clinician and make that diagnosis. And that can be from a mental health clinician, like a therapist, etc., or that can come from a clinical provider. But regardless, it's really important that you actually do that proper diagnosis because not everyone has a disordered relationship. And it's also helpful in terms of treatment monitoring, which we'll talk about more later, in terms of actually being able to grade that disorder and then be able to track those symptoms, the specific disordered substance use symptoms over time, rather than just the level of the use, because the level of the use is not always helpful in telling you whether or not someone is having a response to treatment. So we're going to spend quite a bit of time on this slide. And it's the reason why is like this is their algorithm for treatment, and a great deal of the guideline is actually just like words that explain all the things that you see here in this one visual. And that's why I've decided actually to include the visual instead, because I think it's a really helpful reference tool. You can go through and you can read through the guidelines and see all of that information in print form first, but then just have this for reference in the future. So again, you can see that they're recommending behavioral treatment always as a first line, especially contingency management. And they're suggesting that contingency management for stimulant use disorders is really the standard of care, plus or minus some of those other sort of therapeutic, like therapist level interventions, cognitive behavioral therapy, etc. They also had some notes because of recent research about some technology sort of assisted treatment. And that's things like using apps or telemedicine or digital therapeutics to sort of aid in care. I'm meaning like apps to kind of like help people like remind them to do things, like help them sort of like track their own progress, and things like that, and sort of like use those as part of their care. Again, not saying that that's a standard of care, but something that can be considered. More and more nowadays, there are helpful apps. I especially think there's some really great apps out there actually for opioid use disorder, although there are some that are applicable to stimulant use disorders as well. Now, what this slide does a great job of summarizing is the recommendations for actual evidence-based prescription of medications for stimulant use disorders. So as you can see, they split it into two types here. ATS stands for amphetamine type stimulants. So that would be methamphetamine, but sort of any of those sort of amphetamine type stimulants if there's a disordered use. So under the cocaine section, they go through the different ones that have been found to, again, show some benefit. You'll see there that they embrace, again, treatment of symptoms, especially people who have concomitant ADHD or attention deficit with stimulant medications like amphetamines or even long-acting methylphenidates to treat that. So that's really important, and that is a big change. And we know that using those long-acting formulations of those drugs to help people with the stimulant use disorder, including cocaine, it can be really beneficial because a lot of times we know that a lot of substance use is self-medication. Can be self-medication for mental health problems like anxiety and depression, but it can also be self-medication for issues like attention. You'll also see under the cocaine tab that they're recommending bupropion, which is sort of a cousin of the stimulants, especially also for people that also have depression or use tobacco, because it has those other indications. And so what you'll see in general in the recommendations in this guideline is a big focus on if you're going to prescribe someone one of these treatments that has evidence, but not so much evidence that they feel comfortable calling it a standard of care, you should give it extra consideration if they have one of those other indications for that drug. So again, bupropion is an antidepressant. It's indicated for also for smoking cessation as well as depression. And so if you have someone with a cocaine use disorder who also uses tobacco and is depressed, that might be a really great option. Similarly, if you have someone who also is struggling with alcohol use, you might consider topiramate plus a long-acting stimulant, especially if they also have attention issues. If they just have attention issues and also use cocaine, then you might steer more towards one of the amphetamine formulations. Modafinil is also an off-label treatment for depression. It's also a wakefulness promoter. So again, I think actually of all the medications for cocaine, we're not going to talk about cocaine as much as we're going to talk about amphetamines today, but modafinil pretty much, I would say, has the most research. If you're seeing someone who just like it's a really primary cocaine use disorder, that might be a great option. You can add it on in addition to other medications. You can also consider it also for someone with depression, although that's not strictly based in these guidelines. And like I said, they're also sort of using topiramate just because it has that cross indication with alcohol use disorder. Then on the right side, you see their recommendations related to amphetamine type stimulant use disorders. So similar medications, but again, looking at if those drugs have alternate indications for other use disorders. Once again, bupropion for tobacco or depression, Topamax if they or topiramate, excuse me, if they also have alcohol use disorder, methylphenidate formulations, and we'll focus in on that actually in the coming slides. And then we will also talk a lot more about both mirtazapine as well as the combination of bupropion and naltrexone. Some of you may have heard of the Trivedi trial. We'll be talking about that today in the follow-up lead trial, which was analyses of the ADAPT-2 trial. So we'll talk about that, but especially that combination, thinking about people with tobacco use, because bupropion and tobacco use, with alcohol use because of naltrexone and alcohol use, and then depression because of bupropion. Although we actually know that naltrexone also may have some help with that too, especially in low doses, although the dosing is a bit different for that if we're talking about that combination for amphetamine type stimulants. And lastly, mirtazapine for methamphetamine type use disorders, especially if they also have depression. I would add to that also if they have low weight, because it does stimulate the appetite. That would be another great reason. And then also we'll talk about it. Mirtazapine really is first line for people with sexualized drug use, although that's not so much in the guideline. They really just focused on it for depression. So I will pause here for a couple of seconds to take a sip of water. I've just given you a lot of very dense information on this one slide. I want to give you a moment to digest, and if you have any questions, now would be a great time to open up that Q&A box and type them in so that way we can go ahead and address them later. And I see a question there also about slides being made available. Yes, they will. There's resources at the end And we can also talk a little bit about follow-up about some of those app names. I see some questions about that. All right. So moving right along, the last thing I mentioned off of that previous slide about different medications for stimulant use disorders was about mirtazapine as first line for sexualized drug use in queer people. The reason why I say that is that the only medication that has been specifically studied for chemsex use disorders or sexualized drug use in gay, bisexual, men of sex men, or other sexual and gender diverse people has been mirtazapine. There have been two studies, one in 2011 and one in 2019, both out of San Francisco. Both of them looking at GBMSM, although the second study tried to include transgender people. They tried to include both trans men and transgender women. They only succeeded in including transgender women, unfortunately. There is some indications out there that we know that transgender men, especially those who may identify as gay, or use sort of like gay apps like Grindr or Scruff, etc., that those people may also have some participation in chemsex, but unfortunately they are not really seen in the research as of late, and that's something that definitely needs to be corrected, and it is an important future direction. So in these two studies, you can see they had modest trial sizes, and they looked at outcomes primarily about the urine drug screen, but they also had some really great secondary outcomes looking at both HIV markers, but then also sort of like quality of life and other sort of markers. I really think that when we're doing a sexualized drug use study, a really great opportunity also to secure funding if you're a researcher is to try to include outcomes related to HIV prevention and treatment. So is treatment of the stimulant use disorder also improving treatment retention and virus suppression for HIV? They started to do that in the first study. It can be difficult in terms of study design and powering the study to do that, but I do think that is really important, and I'm really happy that they included in this. And the summary is it really worked. Even with crappy adherence, they found that it did actually reduce the number of meth positive urine drug screens. Although honestly, we know that that's not that really important for treatment. But more importantly, we did actually see a reduction in some of the risk behaviors related to HIV acquisition. And so, again, this is a good proof that in sexualized drug use, treatment of the sexualized drug use may lead to better outcomes in terms of HIV prevention and treatment. We need more research, but I would definitely say when it comes to this, mirtazapine is first line. And we'll talk more about the qualities of mirtazapine specifically that make it useful later. I'll go through like how the drugs work later, but for now, I just want to focus on the research, sort of showing if the drugs work and how talk about the research sort of interventions, how they were structured, etc. You will see that both of these are like medium length studies, only about 3 months, and then some follow up. But in both studies, they used a dose of 30 milligrams of mirtazapine. I do think that is relevant to know. Mirtazapine does go up to 45 milligrams. 30 is sort of that intermediary dose. It's a very safe medication. And so you can really just prescribe 30 off the bat, and there's squirts. You can tell them to take half for the first bit. And if you have questions on that, I'm happy to discuss that more later. But something to note that they're not using the maximum dose of mirtazapine. And that's actually also because of the way mirtazapine works on so many receptors. The way it sort of affects the person at the higher doses is a little bit different than how it affects the person at the lower doses. Alrighty. So specifically, I also wanted to focus in on the ASAM guidelines discussion of using methylphenidates, especially long-acting methylphenidates, to treat amphetamine type disorders. So I think, like I said, it is so amazing that they are finally embracing stimulants to be used for stimulant use disorder. It just makes sense. We have used methadone and buprenorphine for a long time to treat opioid use disorder. We know that people oftentimes are self-treating with these medications. And again, one of those big markers of this sort of relationship is using to feel normal. And if they're using to feel normal, sometimes we just need to find a different way to make them feel normal that's not using that illicit substance and also cutting them out of the cycle. And by prescribing something like a stimulant that can make them feel normal again and allow them to get employment, to get reconnected to their community, integrated into their families and friends and relationships again, We know that that solves those other factors of disordered use. And so that is really like the first step oftentimes for some people in getting them in sort of like into the fold to reduce that disordered relationship. And then maybe eventually it could become a thing where they could taper off of it, but that really shouldn't be the goal. What we're trying to do is get people to be in the physical state that they need to be in, so that way we can try and solve some of those other problems that are also contributing to their disordered relationship with the substance. Now, they do recommend, though, what I first want to highlight in sort of this highlight on methylphenidate for amphetamine type stimulant use disorders, that they be a treatment especially considered for people with moderate or higher use. So in my clinical practice, if someone comes to me and they are injecting methamphetamines, I almost am always going to start with a long-acting stimulant, because bupropion is not going to cut it. Bupropion, sir, is stimulant-like. It's a little bit activating and helps with libido. It helps restore some of the things that people lose when they stop using a stimulant. But if you are injecting amphetamines, especially on a regular basis, a little bit of bupropion is not going to be enough. You may end up needing a long-acting stimulant and bupropion to get some of like sort of stabilized and feel normal again. So especially again for those people with high use levels, which they are defining as 10 or more days per month. But again, I would also consider about injection drug use. You do want to think about that. Now, they also especially said that if there is ADD or ADHD, especially ask people about childhood diagnoses, if they had that, especially as young adults, and they're now adults and they're using these stimulants. Think about aggressively treating that ADHD with an effective medication like stimulants. Stimulants are incredibly effective medications for attention deficit. And so by treating that, you can really sort of also help the cycle, because a lot of times, like I said, it is self-medication. And what I also wanted to highlight from this same section is that they actually recommend considering treating at the maximum or even above the maximum dose approved by the FDA. So again, this is off-label. All of this is off-label. But I'll go into a little bit why that is safe. But that's actually embraced by this guideline. And I think that that is important because it is the first step also of sort of what I think the like research continuum is, to seeing more studies about stimulants being used, long-acting stimulants used for stimulant use disorder. And eventually the pathway to eventually maybe even get an FDA indication is having more data behind it, and also having more data probably at the higher doses that are going to be more effective for people. Because again, if someone is injecting stimulants, and I've worked with people who have injected stimulants multiple times a day, every day of the week for long periods of time, a little bit, a small dose of a long-acting methylphenidate or long-acting like amphetamine type stimulant is not really going to cut it. Now, I will also highlight here that they are only recommending methylphenidate formulations, not amphetamine formulations. Well, I'll talk about the nuances there based off of some other research that I think wasn't considered at this time. But that means that they're really only talking about I want to avoid, they're not talking about your mixed amphetamine salts, etc., like your generic versions of Adderall, etc. They're talking about your long-acting methylphenidate things, but I'm going to try to steer away from brand names. But if you do need those, I can answer those at the end to try to make it clear. There are two big types of stimulants when we're talking about ADD. They're like amphetamine type stimulants and methylphenidate type stimulants. They're really, again, just recommending the long-acting methylphenidate, but there are some actually long-acting amphetamine types that are useful. But by and large, never use the short-actings. That is also in this guideline, and that's just well known. The short-acting stimulants are not going to be useful to treat stimulant use disorder. To the person who asked, is mirtazapine a contraindication to Adderall use? Nope. Definitely not. Although I would not use Adderall for someone who has a stimulant use disorder. Especially not short release Adderall. That's in research, they looked at short release Adderall. It doesn't work. So I would avoid that. Again, I would always use a long acting preparation, and ideally either like so we're talking about a lisdexamfetamine or a long acting methylphenidate preparation, which again, if you need those brand names, I can give you those, but never a short acting stimulant, especially never a short acting Adderall. And even a long acting mixed amphetamine salts, like an Adderall XR, so to speak, that is also not going to be first choice. There's no contraindication, and you definitely can give them both. So a lot of times people with stimulant use disorders, they have a real terrible disruption in the sleep-wake cycle. And so actually giving them mirtazapine to sleep and a stimulant for the morning can help re-regulate that sleep-wake cycle. So it's not a bad idea. And for some people, it's almost recommended. Mirtazapine, and I'll talk more about their clinical uses later, is also really wonderful for people even in active use, whether it's overuse of methamphetamine or a prescription stimulant. It's great for people in active use as a come down medication because it's very safe. And I'll talk about that more when we look at the hartikainen trial. So the last thing I just mentioned about the ASAM guidelines and methylphenidate recommendations was that they said at the highest dose or even above. And what I want to highlight here is a study from 2016 looking at large doses of lisdexamfetamine, which is abbreviated here as LDX, high above the maximum dose that we usually prescribe for an attention deficit disorder of some kind. And this was a safety and tolerability trial. It wasn't really powered or to look at how effective it was, though it does have some data on that. But as you can see, it's a very small trial, just 16 people. So really just looking at safety and tolerability. And now, again, lisdexamfetamine is not mentioned in the ASAM guidelines. I'm going to talk about why we should, though, be thinking about it, and we should be using it, if not preferentially. So in this study, they found that using huge doses of LDX up to 250 milligrams was basically okay. Again, they were looking at safety and tolerability. They also had some secondary outcomes in treatment. And what they found is that for most people, it was well tolerated. Like with all stimulants, there's always sort of that risk of SI, but it resolved on its own. And that in general, like there was no severe side effects, so that you can use those above doses. Now, having a conversation about insurance coverage is a whole other thing. That's really a big barrier. But again, it's important to sort of start working that way, so that way in the future, hopefully we can have more treatments at the appropriate amount. Okay. Moving forward. Now, this trial, I honestly think is the most important trial when we're talking about stimulant use disorder research in like the last 5 or 10 years, because of its high quality and because of the kind of like outcomes they're looking at. So if you haven't heard of hartikainen, it was a study in Sweden. They looked at almost 14,000 people over a pretty good chunk of time. There's a decent age range, 16 to 64 years old. I mean, what they were looking at is people with a diagnosis of methamphetamine use disorder who did not have a diagnosis of a schizoid disorder like schizophrenia, schizoaffective, schizophreniform, or a bipolar disorder. So those were the exclusion criteria. And what they looked at was primary outcomes of hospitalization due to substance use disorder, any hospitalization or death, or all-cause mortality. So this is the kind of giant trial that we're always looking for the highest quality of data. And so that's why I think it's so important, especially when you get to see the outcomes that came from this. Now, some issues off the bat. They did not collect sexual orientation or gender identity data, so we can't really specify it that way. But this kind of trial is like almost like the huge cardiac trials that we think about. Really important to have this kind of data. And what they found, and why I was talking about lisdexamfetamine so much earlier, is that of all the different medications, including methylphenidate preparations, the only thing that was associated with any kind of positive outcomes was lisdexamfetamine. And lisdexamfetamine showed a benefit, a statistically significant benefit for all 3 metrics. Lisdexamfetamine use by people with a diagnosis of methamphetamine use disorder led to less hospitalization due to substance use disorder, less of any hospitalization for any reason, and less all-cause mortality. And so that shows us that the best quality data, that is a big endorsement of the use of this medication for those people, because this exposure seems to have been very beneficial looking at a large group of people. And what they also found is that methylphenidate preparations did have some positive associations with a lower all-cause mortality. So the research that we see of long-acting methylphenidates also being beneficial for stimulant use disorders, I do think that seemed to be supported as well. The big other piece of this trial that I think is important, especially for those of you working with any of you who are client-facing at all, especially who do any kind of client counseling. So I'm talking about sexual health workers or testers or anyone who's sort of doing those like harm reduction or direct counseling roles. Benzodiazepines were associated with a worse risk of all three of those outcomes. So more hospitalization due to substance use disorder, more hospitalization or death due to any reason, and more all-cause mortality. And so the reason why this is relevant, and I'm especially saying it's relevant when we're interpreting these ASAM guidelines, is that people love to use benzodiazepines as come down medicines. It is a colloquial thing in our minds. We think of I'm going to use the brand name here because it's relevant. People talk about Xanny bars and they talk about Xanax, and that's what they think of when they think of a come down medication. But that actually really isn't good. Benzodiazepines are not good come down medications for stimulants, especially when they're patient directed, because they're dangerous. Something like mirtazapine, which is essentially the opposite of meth, it makes you hungry, it makes you less tired. It makes you tired, it makes you less depressed and anxious, almost like the opposite, is a very safe medication. It's not going to interact with a lot of drugs. We give mirtazapine to people with dementia because we know that even when someone can't really speak, it's a very safe medication. Benzos, it's not the same. We don't recommend benzos in people over 65 for the same reason. They're not safe medications, and this large portion of data shows that they lead to worse outcomes. Now, the ASAM guidelines do recommend benzodiazepines for the treatment in a hospital setting of acute and stimulant over intoxication. So one of the reasons why stimulant use is not paid attention to the way that it should be, the way that opioids are, is that opioids, the harm that comes from them is very trackable. You can very easily track opioid deaths and overdoses. You can't per se directly overdose on a stimulant. Like it's not like the same thing as like you take too much opioid and then you stop breathing. If you take too much stimulant or you overamp, it can lead to like a cardiac problem that is lethal. It can cause different lethal problems. It's not to say that taking too much of it isn't a problem. The difference between all drugs and poison is just the dose, whether it's prescribed or non-prescribed, but it's different and therefore less trackable. What's more trackable is like what we are seeing it more pop up in is these sort of polysubstance deaths, and we're starting to do a better job of tracking that. But one of the reasons why these become invisible is because it's hard to track. So anyway, getting back to the point here, the reason why this is relevant to know is they do recommend benzodiazepines for treatment of overamping over acute stimulant intoxication, but that is really for the hospital setting. If you are in an outpatient setting or you are prescribing it in any setting for the patient to like choose when to do it and to use it as a come down medication, do not use a benzodiazepine, use mirtazapine or a different medication. They are not safe. If you have any questions on that, please feel free to ask through the Q&A tool. All right. Alrighty. Yes, if you have questions, I will try and get to those all at the end. Try and add them to the Q&A feature versus the chat. I'm only able to see the chat as a small bubble, so it's kind of hard to read all of these, especially if they're multiple sentences. All right. So moving away from the pharmaceutical recommendations of the guidelines, I want to spend some time also talking about some of those other pieces of the guidelines. Not just we talked about a little about like assessment and brief intervention and behavioral intervention, and then also harm reduction. So this is their little piece on basically collecting a needs assessment. And I think this is really great. It's a really wonderful way for all people, whether they're clinicians or whether they're like sort of like case managers. If you want to do an assessment, this is a great way to do a needs assessment to develop some kind of safety plan. So you can collect this information sort of about drug use habits, about how they're using it, to basically start stratifying what are their risks. And then you can use this to inform recommendations. And again, anyone can give these kinds of recommendations. If you collect the information using this kind of great standard assessment about syringe use, are they injecting? You can then refer them to syringe exchange programs. If they're doing things that you can identify through a needs assessment that are perhaps not the safest way to doing things, if they're using alone, if they're using in scenarios where they're surrounded by people who are perhaps not like friendly, etc., you can do safety counseling on that. You can also start looking at interactions with other medications. You can use other interventions like Never Use Alone. Never Use Alone is a really amazing service. where basically people can call in or use the website to like have someone there if they don't have someone to use with to make sure they're okay. And then, of course, you can look into other resources like Narcan, drug checking, etc. Everyone should get Narcan. For the longest time, I really said that most of the most of the concept of fentanyl being in stimulants was sensationalism. Drug dealers are not stupid. It doesn't really make sense to put a downer and an upper, although we are starting to see that. Now, it is pretty much useless to give fentanyl test strips to people using opioids because it's all fentanyl and it has been for a while. Where I do hand out fentanyl test strips is for people using stimulants and people using downers like GHB or even ketamine, because that is where you will actually start to see that sometimes there is, on occasion, what's the word? Like those impurities in those things are not really impurities, but like that additive. And so you want to make sure that the people are tracking their substances and have the appropriate tools like Narcan and the ability to test for fentanyl and their stimulants. And we are starting to see that pop up a little bit more. In my area of the country, which is sort of the DMV, the DC, Maryland, Virginia Metro, we have seen some cases of opioids being put into stimulants, and then also things like GHB, etc., which of course is a dangerous combination. And they recommend a needs assessment and then also brief intervention. So if you've heard of like SBIRT, which is like screening and then brief interventions, this is sort of what they're highlighting here. And I think that's great is basically you do the needs assessment. Like I said, think of those things you can refer them to, think of the social context, and then also think of referrals. Do they need a program? Do they need a housing resource? Do they need an employment resource, etc.? Where can I refer them for additional medical care related to their substance use, etc.? Where can I refer them to harm reduction services? Who can also do more basically like education and harm reduction? Who can also be a care navigator if they don't have a care navigator and you're a clinician, etc. So they have this nice piece that basically is using that model of screening and brief intervention. And I think it's important to also think about what resources are available to you. So I also want to take this time as a little challenge for the chat too. I'd love if you have any resources in your community that you think are really great that could be built elsewhere. Maybe you have a program that you refer to frequently for stimulant use disorder that's doing something novel. Maybe you have an integration between HIV care and case management or substance use, etc., that you think is novel or special. Part of this this webinar is bringing people together from across the country. And so if you have that and you think that other people might like benefit from knowing, feel free to drop it into the chat now or start typing it about different programs that you've tried that have either worked or not worked that are sort of like you think more unique and especially to your area or region. So speaking more on sort of those referrals and sort of care navigation, these are the ASAM levels of care. I'm not going to spend too much time on this, but substance use care really is a care continuum. The highest level, of course, being inpatient or residential. When someone has a diagnosed substance use disorder, what you're trying to do is sort of just like there's a spectrum of disordered use, there's a spectrum of where they need to be based off of like based on the level of care that they need, based off of the severity of the use disorder and what they've tried. And so this is just outlining that care continuing of being able to scale people up and down. And the point of this is also just to sort of show that like people are always on the scale. They're either in that long-term remission monitoring outpatient or they're somewhere else in the scale, but they're always getting care. That's always included as part of their care is sort of check-ins to see what level of care that they need and that they're being appropriately managed. Okay, and so this part of the guideline, which I think is another really wonderful part of it, is where they show an embracement for harm reduction. Not just where they're saying that harm reduction education piece, but all these things they're mentioning are forms of harm reduction for people who are using stimulants and things that we want both drug treatment centers and HIV prevention and treatment centers to be doing. Talking to people about nutrition if they use stimulants, talking to them about oral health, making sure that they're connected to Ryan White dental if they're HIV positive or just dental care in general if they're HIV negative. Talking about oral health, harm reduction, things like dry mouth rinses, which help prevent the dental decay associated with stimulants. Of course, talking about PrEP and PEP, etc. talking about safety with injection drug use, etc. So it's a really nice, none of this information is particularly novel. It doesn't have to be, but it's wonderful that they include in this guideline. Like I said, it's a huge major shift on their policy, an embracement of harm reduction as it relates to stimulants. And I love that it's in this guideline because it is a comprehensive guideline. It's a great guideline that's, again, embracing the pharmacotherapies, but then also at the same time reminding people about these other pieces that should also be considered. So one of the as we've reviewed the guidelines, I would say pretty thoroughly by now. I want to go over some of the positive and negatives as we sort of like think about them. And now this is like taking an overview. A lot of these we've mentioned. So I mentioned before about contingency management. I think it's a great tool. I also am always wishing for a little bit more about social support services and discussion of that, because the logical reason of why contingency management works, in also that we know from also larger social experiments about like in other countries and other places who are also doing work around substance use disorder, is it's not just like the prize, although obviously we know that gamification and prizes work for other tools as well, but it's really about the need for social services. And I think that's alluded to a little bit in this guideline, but that could be in there more, especially if you're going to include contingency management, like an understanding of the need for social supports. Unfortunately, there's only so much we can do as clinicians, but I still think it's always important to acknowledge. I think that a little bit more focus on the DSM criteria would be great. I think they included it in there, but sometimes, again, it's very easy in medicine to just define the substance use disorder as the use of the substance. And I think it really assumes like an abstinence, at times an abstinence-based goal, or that like true resolution of symptoms is abstinence. And recovery, really, we know, especially when listening to the community, that recovery is self-defined. So you don't want to box yourself in that way. No use is not necessarily restrictive. The other thing that is a little bit of a problem, I can't recall actually if I put the direct slide with a quote, that is problematic, is that they only recommend pharmacotherapy be done by physicians who are certified in addiction medicine. And we really learned a lesson, or I hoped we had learned a lesson from buprenorphine prescribing, that these asinine restrictions on profession and on certifications to who can prescribe this kind of care, all they do is reduce access. They do not improve outcomes, and they do not improve care. Obviously, no one should be doing something beyond their comfort level and expertise, but the whole point of having these resources, having these guidelines, is to get more people to access these things. That's the purpose of a guideline, is to get people to be able to follow something and to learn more and get like and understand the care. And so by really segmenting it off to only one profession within the healthcare, like sort of stratosphere, and only those certified, I don't think that's the way to go. We know the story with buprenorphine, like I said, and I'm so glad that we finally evolved on that. And now there's a lot more access because those restrictions were asinine. I don't like the embracement of that sort of asinine thing here, because I don't think any of us want to go through that same problem of if we ever do get a labeled medication for stimulant use disorder, it being restricted to a small subset, and therefore most people not actually having access to it. It's just an access issue. I do like that it talks that a urine drug screen isn't necessarily a screening tool. It's really more a vital sign is how I like to think of it. And I like that it also looks at special populations like pregnant people and young people. I do like that it mentions things like case management, and it also includes encouragement of people to evaluate diagnoses further. So a lot of people with stimulant use disorder get diagnosed with bipolar disorder or with psychotic disorders when they perhaps don't have a primary bipolar or psychotic disorder. They're just on stimulants. And so it's important to interrogate that. And like I said, I like that it embraces the pharmacology, the pharmacotherapies, as well as the different harm reduction strategies. And also it has a note on there about the need for affirming services for sexual and gender diverse people. I do think, again, that it pathologizes stimulant use a little bit, but overall, it's a really great guideline, a huge amount of progress forward. So I'm really excited about this ASAM guideline, and hope that it does increase access. So we're going to pivot now sort of into our last sort of act, and we'll wrap this up probably in about like 10 minutes to leave about 10 to 15 minutes for questions, because I know there's been a lot of questions in the chat. And these, again, these slides will be available to you, so this is also for reference. These guidelines were based off of the evidence, and what these two slides that go through all of the different medications just for methamphetamine use disorder, I did make this for cocaine, because the list of studies is longer. But it kind of just references the different studies that are out there in the field that support the use of the medication for that indication. So this goes through all the different ones. And I've kind of, I'm going to delve a little bit more into the bupropion trials. So I'm just going to push through this. Again, we already talked about the trials about long-acting stimulants. We talked about avoiding benzos. I would also say be a lot of caution with SSRIs. The way I oftentimes like to think about SSRIs as a mnemonic is they can make people fat and flat. And that those are things that people who are using stimulants really don't want to feel. And there's some indication that they're not helpful. A lot of people, either going through stimulant, they're coming off of stimulants, or who are actively using stimulants have a lot of anxiety for a whole host of reasons. But SSRIs are really not the most helpful way to treat that anxiety. They take a long time to work. And again, they cause like a lot of like issues for those people, like symptoms that they don't like. So probably not first line, something to think about there as well. Now, the last two trials I want to sort of talk about before we wrap up and just do resources is the Trivedi and Lee trials. So both of these papers, I should say, both of these papers were based off of the ADAPT-2 trial, which was a two-stage trial looking at the combination of injectable naltrexone and XL bupropion. As you can see there, it was sort of a stage trial with a good decent amount of number of people, although they were all treatment-seeking adults. And the intervention was 450 milligrams of bupropion. Now, they did actually get there in 3 days. You can get to the max dose of bupropion quite quickly. It's a pretty safe medication. Its only contraindications are people with a pre-existing seizure disorder or an eating disorder. And so for other people, it's pretty easy to ramp it right up. Their primary outcome, unfortunately, was just negative urine drug screens, but they did have some secondary outcomes, and they did use a weighted average, which is helpful. Some more information on the participants. They had to, they verified that they were using methamphetamines at a decent amount. They had to not be using opioids because they really wanted to focus in on stimulant use disorder. And they excluded people who were already who were already getting treatment, who were treatment experienced. And these were some of the outcomes about quality of life and sort of mental health. And what they found is that the combination had a modest but statistically significant benefit. So if you look at the top or at the bottom, on the top, you can see the difference between the naltrexone, the treatment group, and on the right, you have the placebo group. On both sides, also, when you're looking at the graphs, you can see that the difference between placebo and treatment is small, but still there. And so basically what they found is that there was like a small response rate, about 16.5% in the treatment group versus 3.4. And in the second stage, it was about similar. And so what we see is that when you weight it and do the statistical analysis, about a 13.6% benefit total, which leads to a small, like almost just a little bit more than 10% like benefit overall. So a lot of people will sort of brush that off, but that's a 10% benefit in negative urine drug screens. That's very relevant to think about because that is the outcome. And we know that those are not the most important things. These are just the adverse events, nothing really serious. What I want to focus on, which is what they did, is sort of a more as a secondary analysis that is like thinking about what would happen with a longer period of time, more than just the 12 weeks, because treatment included at 12 weeks. And so this was a bit of a predictive way of doing it. And what they found is when you sort of increase the time length, that continued treatment is associated with additional reductions. So longer term studies may be warranted. Now, there's a lot of data on there in summary. We don't need to go through all of it. But the reason why I'm bringing this up is I think it's a very helpful intervention. I think like the guidelines in ASAM were saying, you could definitely consider it, especially for people with concomitant depression and alcohol use disorder. But it really brings us into the last act. I'm just going to skip right past that slide. which is about research limitations, is that at the end of the day, we don't really care about whether or not someone has a positive or a negative drug screen. We care about if they're like working on the other pieces of their health, whether that be comorbidities like diabetes, heart disease, or HIV, or viral hepatitis. And we care about quality of life metrics. And that's what's really missing from studies. Of course, there's a lot of other issues there that we've seen so far, just in general, about like trial diversity and funding, et cetera. And also sort of divorcing substance use disorder research from those social determinants of health. All of those are important, but I think honestly, the biggest issue with substance use disorder research is the primary outcome. So the final takeaway I wanted to do as I wrap up and just show you the resource slide is just that there is a need for research with different primary outcomes, looking at those DSM criteria, looking at comorbidities, and looking at sort of like overall health and quality of life outcomes. And of course, you want that research to be community, have like community involvement through like community advisory boards, et cetera. We want it to be holistic, and we want it to also help build capacity. So with that, I will wrap up. There are two little like resource slides in there, and I will stop talking and we can switch now to the Q&A. Perfect timing too, because we wanted to leave 15 minutes.
All right. We do have quite a few questions. And so forgive me if I pronounce anything wrong, but help me out here. So the first question we have is, can you discuss the increase of crystal meth use among Black gay men? Why this trend? Any stats?
So I think there's two things here. I think part of the perceived increase of use versus before is also that we're paying more attention. So we knew about the huge disparities in new HIV diagnoses, and we know about that like there's 5 southern states that are accounting for a large proportion of new HIV diagnoses. We also know that it is especially in people of color, especially Black people, although there's also higher rates in Hispanic, gay, bisexual men who have sex with men. We know all of these things. Now that we know these things, people are paying more attention, so they're finding more of it. And these are populations that don't have a lot of healthcare access. That is a big piece of it. The social determinants of health are a huge piece of it. And so now that we're really trying to go into those communities and do the research, of course, that's going to like make it seem like there is a new problem there, when in fact there actually also was this problem for a long period of time. I've been talking about Chemsex for a while now. There has been an explosion of research, I would say, in the last 5 to 10 years. Chemsex did not get invented in the last 5 to 10 years. It existed before the HIV epidemic, it existed during, and it certainly sort of changed over time. And I think the advent of apps certainly increased it, but it's always been there. It's just that healthcare has started to pay attention or become aware of it, especially as stigma has decreased a little bit, stigma against LGBTQ communities, which has allowed people to be more honest and do this kind of research. Now, I think it's an incredibly important research population when we're talking about Black gay men, gay, bisexual, and men who have sex with men. If you're talking about why there would be higher rates, is exactly what I was talking about with syndemic theory. People of color who are also in that category of gay, bisexual, men who have sex with men, they've got two identities there and are experiencing two different intersections of oppression. Racial oppression, as well as repression based off of their sexual orientation or gender identity. And so what we find in syndemics research is that oftentimes when you have two different forms of a repressed identity, it's not just that it's like a checkbox, yes or no, you have an oppressed identity and everyone's the same. Oftentimes it's additive. You are worse off or more likely to have negative health outcomes if you are both of those things versus you were just one. Meaning if you were just a sexual or gender diverse person or just a person of color, your risk factor would be lower than if you're both of those combined. It like adds and it's much worse. So really it's about the intersectional identity there. Nothing that is an innate quality of the person, of course, but it's about experiencing those multiple forms of oppression. And when we're talking about people of color who are gay, bisexual, men who have sex with men in the South, we're also talking about a dually oppressed group. We're talking about a group with low healthcare access. We're talking about a region of the country that, besides also having healthcare access issues, that are related to like physically there being enough healthcare. There's also economic issues, there's transportation issues, all of those things combined. And of course, the most marginalized communities are always going to be the most affected. I hope that answers your question. So it's really important to target those communities. And it's also really important, and I think like I can't say this enough, is it's important in the messaging to be incredibly aware that it is not that community doing something wrong. It is the place we have put that community in and continue to do so.
Okay, thank you. Can you discuss the use of the minority stress model as a guide for the AA same gender loving community?
Yeah. I think like even what I was just talking about, it's the same idea. So minority stress can be related to any minoritized identity, whether that be a gender identity, sexual identity, ethnic identity, racial identity, etc. And so minority stress is basically when I say different experiences of oppression, that's the minority stress. So oppression faced based off of an identity, that's the minority stress. And those different minority stresses, because everyone has an intersectional identity, add up together. It's not just like you have one and it's the same as if it were something else. It's not, some people like to think of it as like they'll say the word trauma Olympics. It's not a trauma Olympics. It's just that it's additive. And so I think it's really important to apply that. And that's what I was talking about with like sort of intersectional identities is that when someone has multiple minoritized identities, they're going to be much more likely to develop a disordered relationship with substance use, to have negative health outcomes, to be exposed to viral hepatitis or HIV. And also, we know that when it comes to infectious disease, when it's clustered in a community that is also, it's about the sexual networks, mostly having sex within a closed sexual network, of course, you're going to see more spread in that network and not necessarily out of that network. But yes, minority stress, like versus like experienced depression, it's basically just synonyms. And it's incredibly important. And I think in terms of justice work, it's also really incredibly important, like I said, to recognize that.
Hey, great. Yes, you will get a copy of the slides, a PDF. Yes. I believe this has been addressed, but what are the app names to help with SUD?
Sure. There's a whole bunch of them. I have some stuff in the resource slide, which also links to other websites that have more of the apps. My favorite app is really for opioids. It's called Starting Bupe. But they have like I forget the names of it, but if you even just type, there's like a billion of them, like the 30-day and the 90-day counters. There are all kinds of apps. They're different between iPhone and Android, and I tell people just to find the one that they like. That will help people with like monitoring their sobriety to all kinds of substances. Some of the apps that have been studied in research trials, they don't always actually like make it to the app store to be available to everyone. And basically they do the same things. So if you just go into the app store on whatever kind of device you have, Apple or Android, and you just look it up, you will find a host of them. I actually don't have a whole lot I recommend. And part of that is because they change and disappear. The only one I've really taken with me is just that one opioid one that I particularly like and is stuck around. But yeah, there's a whole host of them. And there's also, I find day counters for people who are goal is absolute abstinence to be very helpful. And so I will tell people to get like a day counter app that helps them with monitor their sort of sobriety. It's the same concept that used to be used in the different 12-step programs about like giving people the coins for like 30 days, 90 days, blah, blah, blah. Now you can do that with apps and also have helpful reminders, etc. And some of the apps also do helpful things, like they help you with the buprenorphine induction, they help you like monitor treatment, etc. And you can even also, sorry, I keep on thinking of things.
Okay.
And the last thing is you can also encourage digital reminders. Like if adherence is an issue, we know, for example, with like some of the studies show that one of the issues with pharmacotherapies for stimulant use disorder is adherence. Setting like an alarm on your phone to go off every day, just like we also tell people to do with their HIV meds or PrEP, etc. But yes, you can go to the next question. Sorry.
Thank you. What if the drug of choice is methylphenidate, such as Adderall? How would you treat that using medications?
Sure. So I think it depends on the exact drug. So Adderall is actually an amphetamine type stimulant. It's not a methylphenidate. Methylphenidates that are short acting would be things like Ritalin, etc. So if they have a use disorder for a short acting stimulant, I do think that you would consider putting them on a long-acting stimulant. Especially if they're also starting to use like methamphetamine on top of that because they're running out of the prescribed one. I think that's something that you can consider. You also could consider if they're at a low level of disordered use, trying to use something similar like bupropion, which is also activating, as an off-label treatment for attention, etc. You could consider that. But in general, that's why I say always use the long actings. I actually also, I mean, this is a whole conversation in of itself. As many of us probably have experienced, there's been an explosion in the prescription of stimulants for adult attention deficit. And that has largely been driven by marketing companies that have convinced everyone that they have ADD or ADHD. Statistically, it's just not possible. But the amount of people that are on stimulants, like I saw one study that said an over 300% increase, which is why there's so many shortages. And so, if you're going to prescribe an adult stimulant medication, I do, and I always like for attention as well. In my practice, I only use long actings as a practice. They're just safer, even if you nom a ton of them, as I showed with that lisdexamfetamine study, they're still safer. So that is one of the considerations. The last thing I'll say is that if you have someone who's starting to buy street stimulants, either street versions of what they think is Adderall, but is actually like methamphetamine, etc., the reason why I also want you to really give serious consideration to prescribing a long-acting stimulant is the harm reduction sort of a thought of it, which is that there is no world in which injecting meth or taking a street stimulant that was made God knows where is going to be more safe than you prescribing a stimulant and monitoring it. Of course, you want to monitor it. You're not giving people huge like things and just never saying hello to them. You're doing basic clinical monitoring it. But there's no world in which it's not going to be better for them to be using the prescription one. So I would not automatically always just assume that you need to cut those people off. In fact, a lot of times if you just sort of cut people off without like a plan, that is what it's going to like lead people to seek out sources and sort of get them connected into places that we don't want them to be connected.
Thank you. When treating ATS with stimulants, would you put in place any protocols to reduce risk of abuse of the prescription?
So the ASAM guidelines talk about pill counts and things like that. I actually am against those sorts of things. Again, like I said, even if they like, as long as you are just prescribing them once a month and they have that one for like thing like a normal any other normal prescription, if they take them all at the beginning, I mean that's sort of like on them. I don't think like it's not going and you're not like going to be prescribing extras. The reason why I don't like pill counts and some of those other things is they become very punitive. And especially because we're dealing with a lot of people with medical trauma who have perhaps interacted with the carceral system, this very like patriarchal system of like, you need to take it this way and do it this, whatever. I don't really believe in that. I really come from a harm reductionist approach. What are things that you can do? Just best practices like with any medication. When you're first working with someone, if you're really worried about them and they are very much in active use, don't prescribe 30 days, prescribe 7 days at a time, ask them to come back and keep talking with them and interviewing with them rather than saying, show me your pills. That is going to build a therapeutic relationship and be much better prescribing a smaller quantity and just closer monitoring than doing some of those other sort of again, very punitive models of care. So that's what I would recommend. You can do shorter intervals, smaller quantities. You can make sure that there's a system of accountability, make sure that there's also room for people to be honest. When you hold prescriptions hostage, it makes people lie. That is why people lie to clinicians. When you say, like, when you start an interaction, and this is what I usually do, is saying, like, you are going to walk away with this prescription, it makes people feel like they are not in auditioning to get treatment. And then it's when you can actually have an open and honest conversation about if something is working for that person. And so that's what I would say is try to bring down those barriers, try to make it less patriarchal, try to make it less punitive, just try to like encourage that like area of honesty. And that comes down to sort of a give and take. And it comes down to a thing that's really difficult for a lot of clinicians, which is seeding some of the powder. the power. Like, there's a big power dynamic between patient and provider. And for too long, it's really been like, I am the provider, I know best, I'm going to sit here and tell you what to do. And that's really just not a helpful model. You want to like treat it like a treatment community. You want to bring that person in on their care and treat them as the decision maker, even if it's a controlled medication. Because, like I said, what can they do with a prescription with a long acting stimulant that is worse for them than injecting street meth or smoking meth or whatever it is that they're probably doing? There's very little that you could do that is more harm than what they are already doing that you are trying to reduce.
Thank you. So we have one more question left. It is a three-part question. I'm just going to read it. When choosing to use long-acting formulations for stimulant use disorder, how do you balance risk of continued illicit use of misuse of the prescribed med? How long of a supply do you typically start with? And does research support any program similar to methadone with daily dosing?
Mhm. Okay, so there's some good questions there. Um, yeah. I'll start with the first one. So, like I said in the last question, usually just like if you're starting someone on buprenorphine, when you first start someone on buprenorphine, if you're doing a home induction, you're not prescribing them 30 days. You're prescribing them 7 days or maybe even just a couple of days and asking them to come back or following up over telehealth. Especially when we're talking about our Chemsex patients, I do a lot of this over telehealth. The reason being is that people with stimulant use disorders often have very disturbed sleep-wake cycles. And people also sometimes are unhoused and they're floating between chemsex parties and they don't know where they're going to be. So asking them to be at a certain time period at an exact place is difficult, but reaching them through telehealth can be easier. So I would suggest being a little bit flexible with the modality as a way to also make sure that you're still doing good treatment monitoring. I'm sort of like, again, about that give and take. Certainly prescribing smaller quantities at the beginning, usually starting with 7 days and seeing how it's doing. Also because like I don't start anyone at the highest dose of the stimulant. I start them probably like one or two rungs from the lowest dose that there is. So if we're talking about lisdexamfetamine, I'm probably starting them at 30 or 40 milligrams. If we're talking about the generic form of Concerta, we're talking about like 27 milligrams. If you're talking about the generic Metadate CD, you're talking like, again, 20 or 30 milligrams. And when you come back in 7 days, you also might be raising the dose. And so that's the other way also that you can kind of get like sort of them to buy in treatment and then also make them understand that we're not just doing this to police you because you really want to avoid policing patients. It's built into so much of our substance care and it is, I mean, ethically, I think it's wrong, but it also doesn't work for people. Like being policed is not like a positive way or like for things to continue on or for treatment to work out. In terms of observed dosing, methadone should not have observed dosing. That is also wrong. We have known for the longest time that is worse, that we should be doing take home protocols. It's obscene. If you ask me, I should actually stop boxing, but if you can prescribe Oxycontin for 30 days, you should be able to prescribe the treatment for Oxycontin use disorder for 30 days. So I am not aware of a ton of research for observed dosing. I do not think that that is the solution, though. And again, if we're talking about a stimulant use disorder, again, these are people even more than opioid use disorders, I would say a lot of the times that have incredibly hectic schedule. Their use disorder is something that keeps them awake all the time. So thinking that they're going to be able to show up every day to the specific state and time to receive a treatment in the way that we want them to receive it, it's not really meeting them where they are, and it's not going to be that realistic. But again, you do want to have some safeguards. Don't be prescribing people 90-day supplies and like obviously never monitoring them. Just basic using your clinical intuition.
Right. Thank you so much. That was our final question. Um, yes. So we are right. We're a little over 11 or 11:30.
When, yeah.
1:30. But if you all could take some time to pull the link for the evaluation in the chat, we would greatly appreciate it. Yona, we really appreciate you being here today. Thank you all for your time, and we'll chat offline.
Thank you so much. And feel free to connect with me on LinkedIn, etc. And yeah, thank you so much for being with us today.